So I'll be talking about the PC rent, and I'll be showing two cases. In one of the cases, I was lucky to manage. So in this case, I've removed the chopper. My settings are very high, but you see that I'm doing the vacuum-emulsification in the peripheral part, and you can see the small PC rent taking place. So when I tried to lift and remove it out of the rexus margin, because this part was sub-incisional and it is very difficult to collapse, and you watch that my rent gets extended. So now I put on a viscoelastic, and when I try to put on a viscoelastic, it causes the further extension of the rent. So now my first job was to really bring it out of the capsulorhexis fornicis and secure it into the anterior chamber in front of the iris. So I was able to collapse it, bring it forward. Now it is secured, and I'm relaxed that it is not going to drop down. And because these hard cataracts do not have so much of a epinuclear plate and cortex, so the main management remains with the removal of this nucleus fragment. So I enlarged the incision to 4 millimeter in size, and I use my own technique, what I call as a chopstick technique. And usually I avoid doing phaco in presence of the PCR because I feel that there are chances of further extension of the tear and this nucleus may drop down. So with the nearly 4 millimeter incision, with the two instruments, I tried to pull it out. Probably it needed a little bigger incision, it would have come out in toto, but there is no problem. I crushed it and slowly removed it. This technique is very good in the sense that the chamber is always maintained. We do not press on the lip so that the vitreous will not come forward. And these are the least bulky instruments. And mechanically, slowly we remove this part. And after removing a reasonable amount of this, you can inject further viscoelastic. And I thought, okay, now reasonable amount of this nucleus has been broken and removed. And now the pieces have become a little smaller. So I was worried that the small chunk may drop down. So I pushed it onto the one side. And then I went for the IOL scaffold, placed the lens on front of the iris, and then went behind the iris into the sulcus. Then we placed the trailing loop and dialed it because now this is also placed in the sulcus. You can see a little bit of bleeding over there. And again, I usually avoid doing phacoemulsification in these cases. By any chance, there is a vitreous is there which you may pull, and then I again remove it again by my same technique, manually by the two instruments holding it and pulling it out. Once this was done, to be 100% sure that there is no vitreous, I did the remaining removal of the viscoelastic, cortex, and blood clot, everything by the vitrectomy cutter, because if anytime you feel that there may be a vitreous, you can actually do the vitrectomy. So this clot was removed, and once this clot is removed, all the viscoelastic is removed. And before I withdraw my irrigation port in all cases, even in routine cases, I do not allow the chamber to collapse at any stage, particularly in presence of the PCR. It is absolutely mandatory. I do the optic capture because the capsulorhexis was of reasonably good size of 5 millimeter. Once the optic capture is achieved, I inject the air before withdrawing the irrigation port, and before leaving, I put on a diluted tricord to ensure that there is no vitreous, and the wound was properly sealed to make sure it's not leaking. Now I showed next case, which was really, I was not fortunate. I was called in the middle of the surgery, and you can see the trench was not deep enough. I tried to deepen the trench. Iris was a little floppy. The pterygium head was already removed. And when we tried to divide the nucleus into two, we could not break it into two. The central part is attached, but the peripheral part is separated. So I go and try to chop it, and you can see the grip is very superficial, so I could not actually create a crack. And meanwhile, the iris started collapsing, and the pupil started becoming smaller and smaller. And once we went in, pulled the iris in from the side port, never pushed the iris from the same port from where it is collapsing, but still there was enough of iris damage. We put the amalgam ring, tried to separate it further. And but this malgering was not so good because it was already ETO, probably had less strength than what we needed to have it a full dilatation. So we planned that both the ends are well separated, only central part is attached. So we thought if we can remove on the both the ends half of this segment, we'll be able to handle the central part afterwards. So with the high vacuum setting, we tried to separate and chop. So one piece we could take out easily. We kept on crushing and kept on removing it. And as you can see, my parameter settings were quite high. Vacuum 36 cc and vacuum setting of 600 I was using. And while I was feeling that's going on absolutely okay, one piece we could remove. Then we went on to remove the another piece. And here the reflex is a little too bright for the comfort. And the nucleus mobility was also not so good. And one stall has come out of the Malgren ring. And my suspicion was all right that the patient has developed the PCR. So now with such a huge nucleus inside and the Malgren ring one stall out, and people already iris damaged to some extent. So I had no choice. Now you can see that there is a vitreous coming from the side port incision. So the another option was that we drop this nucleus into the vitreous cavity and put the lens, let the posterior segment surgeon manage it. So I tried to bring this huge nucleus out of the rexus margin and trying to pull it out. And with some effort, the central bridging fibers helped us in that. We could lift it. And once it was lifted, we enlarged the incision to nearly 7 millimeter or so, 6-7 millimeter. And again, I use my same technique of putting out with the two instruments. And we inject the viscoelastic once again. And by this time, we were not sure about what is the status of the capsule. And finally we did the vitrectomy. And you can see there's a lot of iris damage. So we closed the wound and left it as such and did the secondary IOL implantation after 2 weeks. So this was the worst case I have handled for a long time, where in spite of all the efforts, we could not put the IOL in the primary case. Thank you for the opportunity.